It is here now. I think based on the arrangement, I'll have to use the paper because I cannot run away from this and I can't get now closer to the screen. So just allow me to use paper. Now, if you thought we are just good in statistics, you can confirm that we are also good entertainers from our choir. That can't go unnoticed. Thank you, KNBS choir. Great. Good. So we go to the next slide, third one. There. So just as an introduction, the DHS 2022 was actually implemented by KNBS and of course with a lot of support from Ministry of Health and a number of development partners together with government bodies, and you'll be able to see that one in the next slide. I'm just still recognizing the role that has been played by UN Resident Coordinator's Office for the great support that he marshaled to give us in this. And you'll be able to see some of the UN family members that have supported us. The big support, as I mentioned, came from US Aid. It is a support that even when I retire from the government, I'll keep on appreciating, because it is without that support, we wouldn't have taken off. We wouldn't have taken off. They supported us to the tune of over 3/4 of resources that were required. Is that not massive? And we really can't appreciate that. Thank you so much. That's great. So we go to the next slide. These are the institutions that have really supported. Now, let me start with the logo of the government, the Republic of Kenya. That logo is representing a number of partners. We have Ministry of Health there. We have KEMRI. We have National Council for Population and Development. We have the National Gender and Equity Commission. We have the University of Nairobi, represented by the PSRI. We have Jomo Kenyatta University of Agriculture and Technology. We have the Bomet University College. We have the State Department for Gender. And of course, the mother State Department is there, the State Department for Economic Planning. I'm not sure if I've left out any public institution that supported this process, but all the government institutions are represented by that logo. Now, what is not appearing there is the Statistics Sweden and the Office of the National Statistics UK. They gave a lot of technical assistance, which resulted into the work that we have come up with. So for yourself, you can see the partners that are there. Bill and Melinda Gates Foundation was not there initially. But when we realized that we are not meeting our goals after starting the survey, they came on board in a big way to give support, and this is something that we also appreciate. So that is the composition of the team that has supported and is still supporting. Like the resources from World Bank, we are going to utilize them in our next phase of activities going forward. So much for that. We move to the next, and that is the primary objective of the 2022 DHS is to provide up-to-date estimates of socioeconomic, demographic, health, and nutrition indicators that are meant to guide planning, implementation, monitoring, evaluation of population, health, and nutrition programs at both national and county levels. And it is because of the county requirement that has made the survey very big, because we needed to have quite a large sample to have that one done. The 2022 DHS is actually the 7th one, stemming from the first one was in 1989. Then subsequently we have had 5 others which the last one was in 2014, and it is now that we are launching the next one. So it has taken a bit of time for the reasons that we have earlier explained. So as we have mentioned, it is giving indicators at the national and county levels, but we have also tried to break the national one into urban and rural. Now, before you get to the results, this slide should give you comfort. I think it is that slide plus the next one. But basically this slide should be able to give you the comfort of the quality of the results that we have generated. That first, it was done in a new master sample frame that KNBS is running, and is called Kenya Household Master Sample Frame, which we developed and we are maintaining. We are still developing some other components, but what we required for the DHS was properly developed and updated. And so we undertook from our design, we undertook to take 1,692 clusters for this survey, and they were broken down into urban and rural. When you look at the component of the rural, of the urban, it looks bigger than the size of our urban in Kenya. Our urban is only about 28%. But when you look at the proportion that we took of 666 clusters, it is higher than that. The reason was to help us generate enough cases for analysis at the urban level. But of course, when you are now doing the weighting, you take it back to where it should belong to after getting the enough cases for the correct representation. And so that is what we took. So that was the stage one. We have, in our design, we have 10,000 clusters countrywide. And we only took 1,692. So that is the stage one of the sampling. This is second stage. Within each of those clusters, we sampled 25 households. But later on, you realize that based on the tools, there are cases where we went to half of the households, and that will be coming up ahead. Now, the interest in this survey were women of age 15 to 49, and for female, it was 15 to 54 years. Then we took anthropometric measurements for children, women and men. And for children, we are talking of those who are below 5 years. And that's why we are talking of 0 to 59 months, because that is the focus of interest for this survey. Now, the next one is the tools. We had a number of tools, of course. We had the manuals, which were guiding us. But in terms of questionnaires, we have had a number of them. We had the household questionnaire. We had the short and long and short. Short were covering half the households, so that we are able to get the county level estimates. And we had the biomarker questionnaire, where we are recording the anthropometric measurements, that is the height and weight. And then we had the field worker questionnaire, which was basically to help us deal with the quality issues of what each one of them was doing. Now, unlike the past, where we have been translating the questionnaire into many local languages, this time we only did it in English and Swahili, and that is majorly because it was a copy survey. But at the same time, we have noted previously that even when we do the local languages, our field interviewers are not very keen in doing interviews in mother tongues. And that gets back to us as parents, that we have denied our children the knowledge to understand their local languages properly, because some are really struggling. Some are struggling. So for this survey, we made sure that we were safe with English and Swahili. So in the questionnaire, the CAPI questionnaire, it was done in those two languages. Now, so having covered that, you have seen the design for the study and the representation of the population when it comes to this study. So the household questionnaire was giving a lot of details, which I don't think I really need to get into now. Some of the details have not been analyzed in the current key indicator report that we are going to release, because they are meant for the main report. Women's questionnaire, again, I might not need really to dwell on it much, but it captured variables, a number of variables that were leading to the calculation of indicators of what appear on the screen. The next one is the man's questionnaire. The conspicuous area on this is the female genital mutilation or cutting under the man's questionnaire. This was simply for getting the perception or the knowledge of FGM by knowledge from men. So it's not a mistake for it to be there. Now, the next one is on the biomarker questionnaire, which for children, it was covered in all the households. So all the households that we had 40,000, I think 40,200 households that we covered. You can multiply 25 by 1,692 to get the number of households that we were expecting to cover. I think it should be around 40,200. Now, then for women and men of those ages that are specified, we did the biomarker questionnaire in half of the households. So those households that were sampled for man's questionnaire, we covered we dealt with the anthropometric measurements. And of course, I said that for the field questionnaire, it was just meant to help us get to have the characteristics of the interviewer, which was helping us to analyze the quality. Now, before I go deep into this, I would just wish to request that we have the team that has really been working on this. We had two levels of committees. We had the National Steering Committee, which was represented by whose membership were drawn from the leadership of the institutions that were involved in this activity. And then we had the Technical Working Committee. I'm not very sure if I need to ask the National Steering Committee members to rise up for you to see them. You know, they're big guys, but with a lot of humility, kindly let us see the members of the National Steering Committee for the DHS. Madam Bernadette, I'm seeing you here. Kindly just rise up. The national, yes, I can see Washington at the other end. And even up here, we have a member. I was telling you that we have big shots, and I was very reluctant to ask them to stand. So we have a number of them. Thank you so much. I see Dr. Ann Kasakala, Director PSRI. Thank you so much. Then next is to request for the Technical Working Committee members to stand up. We are a number of us, me being one of them. I was cutting across. I was in the national and the steering, and the Technical Working Committee. Let's just rise up. That's a team. We have a team from NCPD, we have a team from UNICEF, we had a team from UNFPA, we had a team from KNBS, we had a team from in fact, Julius was representing the UN Resident Coordinator's office, and we had a team from where? Yes, Ministry of Health. Ministry of Health had the highest number after KNBS. Thank you. I'm not able to see the anti-FGM board. Yes, thank you. Of course, Cambridge. So we had all the representation from all the institutions that were involved in this. So the work that I'm now presenting here is actually contributed by those personalities, either at the policy level, where we are even sourcing for funds, or at the technical working committee level. But that does not mean that other fellows were not part of this, because whenever these officers were busy on DHS, there were other officers who were coming in to support those processes, some of the work that we were meant to undertake. Now, we undertook training at different levels, so I'll not go into the details, but we had the training of trainers, which brought together the technical working committee members, the ones who had stood up, and a few others who might not have been here. They trained for a period of time, after which they went and trained the team that was meant to do the pilot. We started training in 2021, December, finished that training in January, and the team did the pilot, after which we embarked on the full training for the main exercise. And for the first time, we trained for 28 days because the tools were larger, the demands were higher on those tools in terms of quality that we required. So we moved away from the traditional training of 21 days to 28 days. That was such a long training. And of course, then after the training, we went to the field, did work, which was spanning for 5 months. From 17th of February to around 13th of July, we were in the field. So you can understand the kind of work that has gone into it. As we were doing that, we had 48 teams. Each county had one team, but Nairobi, because of its size and the many clusters that were there, we had 2 teams. That's why we had 48, which had the composition of a supervisor, 1 biomarker, 3 female interviewers, and 1 male interviewer. Most of the questions were female related, and so we needed more females to be part of that. So now we can get into the results. So ordinarily, it is important to get to know the level of coverage. In terms of households, we had 98% coverage. In terms of women who are meant to be interviewed, we had 95% coverage. And for men, we had 87% coverage. Men are very elusive. But tumezoea, we'll try our best to improve on the coverage for men. They are normally very difficult to cover. You have to go very early in the morning or late in the night, or you time them over the weekend. But 87 for men is not a bad one, having gotten 95% for women. So this slide here is showing the coverage of the health insurance. How many of what proportion of our population is actually covered by insurance? So at the national level, we have women being 26% and men at 27%. When you break it into urban and rural, then you are able to see that urban, the coverage of the proportion of urban residents who are covered by health insurance is higher than that of rural, and of course, in urban, men tend to be more covered than females, but really 39 and 41 are not really big differences. Now, you can see it is low. And I think for what I got in the night, that is the reason as to why we do not have the CS Health, PS, the two PSS and the DG Health, because they are discussing this thing, that issue of insurance coverage for the population at a high level, and that's why they are not here, I believe. So with that said, we move to the next one. We made an attempt of having some component on disability, so we had a module for disability in the questionnaire, and so we dealt with the 6 domains of the Washington group of questions that are recommended for such an activity. This one is actually meant for census, but because we are not doing full-fledged disability survey, we confined ourselves to the Washington group of questions that are meant for surveys. And so the coverage is as what you are seeing. The highest cases of disability is on vision, which is seeing. And then the next one is on walking or climbing stairs, that is physical. And then you are able to see that females are more affected at 12% and men at 10%. Now, these figures are slightly different from, they are higher than what we got from the census. These figures are higher, and you know, surveys normally are more precise than censuses, and so we are comfortable with what we have. Now, the next slide is on the education level of survey respondents. This is key. This slide here is very key because it has given the characteristics of the population that we dealt with to give us these results. So first of all, we confined ourselves to those who are within the age of 15 to 49. And within that, the education levels are and distribution is indicated by the 2 bar graphs that are there. So we have for men, we have for women, and we have for men. Those that did not have education at all, we have women being at 6%, and females being at 3%. In terms of those who had a primary level of education, they were the same at 36. Those who had secondary, not very different, 38 and 40. And so that is basically the distribution of the population that we covered in our sample as at the survey time. So those characteristics will play in a big way in the analysis of the results. Yeah, you might not be able to see all of them here, but when you go to the report itself, you'll be able to see the breakdown of analysis done by indicators and looking at different levels of education. And that's how key that particular slide is. Then the next one is what one would want to pick and run away with, and that is the fertility level that we have received from this survey. We have noted from the results that our total fertility rate is 3.4%. This is down from 3.9% that we had in 2014 DHS. And as you can see from the trend, we have had the fertility levels going down. And this is the joy that we have. We still expect it to go down if our policies and interventions are still pointing in the right direction. But there's a disclaimer to what you are seeing on the screen, that the previous DHS series of 89, 93, and 98, we did not have the northeastern and the northern counties of Kenya considered in those series of the survey. They were not there. The reason being that at that time, or during that period, the Bureau had not developed the master sample frame for those areas. So we would only cover the rest of the country minus the northern part of the country, because they were ASAL. Okay, because I cannot tell, because I was not there then. I cannot tell much about that. But what I know is that the frame was not covering them. But from 2003, we have managed to have frames that are covering all parts of the country, and that's when it is really representative. And you can see that we have some plays around 5.4 and 4.7. Otherwise, I'm sure if they were covered, those figures would have been a little bit up, and you'd be able to see a trend coming downwards, as it is depicted from 2003 onwards. Now, the next one is on the teenage pregnancy by education level, and this is a slide that is not very good, because ordinarily we would not expect to have teenage pregnancies. But as it is from the survey, it stands at 15%, which is not a good thing to see. Now, let's break them down by the levels of education. Remember the slide that I mentioned to you about the characteristics of the population in terms of education levels. For the no education people, 38% of them were pregnant. For those who had a primary level of education, 20% of them were pregnant. And the story goes on to those who have higher level of education beyond secondary. 5% of that group were pregnant. Remember, we are restricting ourselves to those who are within the age of 15 to 19. Those are the teenagers that we have considered here. So we can go ahead and unpack it a bit and see what it is at the county level. And this is where we can now see where some of the problems are that we need to tackle. And this is one of the areas where the COG would really need to work hard so that counties can do better. Now, the ones that are indicated red are actually having the highest pregnancy prevalences in those particular counties. So we have Samburu at 50%. You can imagine those fellows of age 15 to 19, half of that group being pregnant in Samburu. Then we have 29 in Marsabit, we have 36 in West Pokot, we had Narok with 28, and we have Meru with 24. I'm not sure why Meru, but the other places you could attribute it easily to early marriages. I'm not very sure of Meru. So those are what we are seeing from at the county level as concerns that particular indicator. Now, fertility preferences, we move to the next, fertility preferences. This percentage distribution of married women, age 15 to 49, by desire for children. So we are restricting ourselves to the distribution, married women of ages 15 to 49. So those who desire to have another child, 30%, another child later, 30%. Those who are willing to have a child soon is 17%. Those who do not, those who want normal, or those who are sterilized at 46%, and those who are declared infecund, that is those who are not able to give birth, are 2%. We move to the next, which is current use of family planning, and we are able to see we have two main ways of family planning methods. We have the modern method, we have the traditional method. So for those who are using the modern method, they are 57%. And those who are using traditional method, they were 6%. But at the national level, when you combine all of them, those who are using any method, they are 63%. Now, you could be troubled with the maths there, but when you look at 57, after 57, it is broken down into the various components that feed into the modern method. That is, we have injectables 20, implants 19, pill 8, IUD 4, and there are others which are not given there, like sterilization, use of male condom, and the like, which all of them account for 6%. So when you add those ones, you'll be able to get the 57. But the 6 that is at the end is actually a different 6 for traditional method. So the current use of family planning stands at 63% at the national level. Next. So that is also broken down by counties, and for counties, for the purposes of this of the presentation today, we decided actually just to use the map to show what they are. So it is a visualization that we have done here, rather than listing all the percentages against each county, which then would be very difficult to compare. And so, sorry, I talked of Kenya is 57%. That is modern. Yeah, so we're dealing with modern. Yeah, so it is 57% is modern, just correctly as I had said. And so we have just broken down the use of modern family planning by counties, and you can see those that are very good. The good ones are the good ones are given in. Do you have them in colors? I can see we have 57 Meru, we have Kiambu at 68, Nyeri at 71, Tharaka-Nithi at 68, Kirinyaga at 71, Embu at 75. So those are the the best users of modern family planning method. And of course we have those that are not doing very well, like Samburu is at 25, we have Garissa at 11. We have low cases also, and you are able to see them from the slide. We go to the next one. This is the total demand for family planning. And here we are talking of percentage of married women age 15 to 49 years with unmet need, met need, and total demand for family planning. So in situations where the current use of any traditional method or any modern method, those are demands that are satisfied, and they are accounting for 57%. And this is the very same one that we had seen earlier. Then we have the unmet need, which is 14%. But if you go to the next slide, it will be able to give you more insight of what is happening. When we are talking about met needs, then we are able to see that from the previous DHS series, and this one we are starting at 1993 onwards, we can see that for the met needs, it has been rising. In 93, the met need was only 33%, which was very bad. It improved to 39, then was stagnated a bit at 39 again in 2003, then moved to 46, 58, and now we have the met needs at 62%, which is a great improvement. And as we are meeting that demand, then it means that the unmet need is dropping, and dropping tremendously, as you are able to see, from 35 to 28 to 27, 26, 18, sorry, and now we are at 14, which then means that there's good improvement. In terms of demand, we are also able to see that it has improved all the way from 68 in 1993 to 76 in the current situation. So we go to the next one, which is on maternal care. And this one is talking to the case of the last 2 years preceding the survey. Percentage of women aged 15 to 49 who had a live birth and or a stillbirth from most recent birth or stillbirth. We can see that those who received antenatal care from skilled providers was 98%. And skilled providers are, when we talk of skilled providers, we are talking of doctors, clinical officers, nurses, and midwives. Those are the categories that are able to help mothers deliver in a safe way. And so it is good that 98% were able to receive antenatal care from the skilled providers. Then there are those who made 4 or more antenatal care visits. It was standing at 66%. And then we have those who received postnatal check during the first 2 days after birth. There was 72%. And so that is not a bad situation. Percentage of live births or stillbirths delivered by a skilled provider, 89, and then delivered in a health facility at 82. Of course, we decided to have delivery in health facilities being 100%. So we move to the next one, which is now breaking the very same slide that we have just seen into counties. And we are able to see those who got assistance during delivery by county, and we have Elgeyo Marakwet having 98%. It is more than it is higher than the average. The average is 89, and Elgeyo Marakwet at the end, it is not colored, but it is 98%. Then we have Samburu. No, we have. I'm trying to get the highest ones. Samburu, I think that's one of the lowest cases. Not, I think it is true. Then Kisumu at 98. We have Nyandarua 98. We have Nyeri at 99. That should be the highest, together with Nairobi 99. Kiambu 98. Those are the counties that have performed the best. But we also have counties whose cases are much lower than the average. Turkana 53. Samburu 57, Wajir 57, Mandera 55, and Tana River 59. Those are the lower cases that I think the systems will be able to help in getting better. Not sure if it's about lack of skilled healthcare providers, or it is for some other reasons. Now, so when we look at the trends in terms of assistance during delivery, which is still the very same topic that we are on, but we are looking at it in terms of the trend all the way from 89 to 2022, and we can see there is quite some progress, but of course we still stand with our caution that 89 to 98, we did not factor in the ASAL cases, but generally there has been improvement over time, because In the 2014, it was only 66, and now it is 89. So that is a great improvement. We go to the next one, which is on vaccinations. A child age 12 to 23 months is considered fully vaccinated, that is having received basic antigens, if the child has received 1 dose of BCG, 3 doses of DPT, 3 doses of oral polio, OPV, and 1 dose of measles, rubella. I'm seated next to the health expert here, but I did not ask him why Kenya has its own schedule, which has added a few more vaccinations for, in our case. The Kenyan national schedule is having more. So other than what is on the left, we have the last 3 bullets being added there as 1 dose of IPV, 3 doses of pneumococcal vaccine, and 2 doses of rotavirus. So those ones are added. I believe the health guys, when you'll be speaking, make it very clear, because that one I'm not able to make it clear as to why we have the standard one and then we have the Kenyan case. It will be interesting for the public to get to understand that. Thank you. Now, then we move to the next one, which is on vaccination coverage by residents. We can see that those who are fully vaccinated in terms of getting the basic antigens, it is standing at 80%. And here, it is regardless of the distribution of the population, whether urban or rural, it is 80%. And so that is where we are. But when you do the strict bit of the vaccination requirement, then we have noted that the cases are falling down to, at the national level, it is coming to be 55% rather than 80. Then for the urban, it is 56 rather than 80. And for the rural, it is 55 rather than 80. But all the same, all of them are actually similar. It doesn't matter where the population is. Seemingly the uptake is kind of the same, regardless of whether you are in urban or rural. But that is the situation. So the strict sense has a lower coverage, and the loose one has a higher coverage. Now then, vaccination coverage by counties. Again, we have just broken down what we have seen at the national level to what we have here, and this one, it is giving it at the basic, we are talking of the basic antigens, the relaxed case, which is 80% at the national level, and we are able to see those counties that have done very well, one of them being Vihiga at 96%, we have Nyandarua at 95%, we have Mombasa 93%, Murang'a at 95%, and we have Tharaka-Nithi also at 95%. However, there are also those counties that have not done well, and they have given in red, where we have Samburu 60, Turkana 60, we have West Pokot 49, we have Wajir 49, Mandera 29, and Garissa 23. Those coverages are very low in those counties, and so something has to be done very quickly. Now, symptoms of childhood illness and care seeking. Of course, children are normally very, very fragile at that lower age, and there is a need to check on some key symptoms that would make them uncomfortable. And we have the acute respiratory infection, ARI, and we have fever and we have diarrhea. Those are the main ones that are very common with children. So it was noted that for children, it was 2% ARI, and fever was at 17. Then we have diarrhea for children, it was at fever 17 and diarrhea at 14. Now, these cases, the questions went ahead to ask if one sought for treatment, and for the few cases that were noted for the acute respiratory infections, 82% of the cases actually sought for treatment. 70% of those who had fever sought for treatment, and 57% of those who had diarrhea also sought treatment. The next one is on the trends in nutritional status of children. And here we are talking of percentage of children under 5 based on 2006 World Health Organization Child Growth Standards. And we can see it is measured by the element of stunting, wasting, and overweight. And we can see that for stunting, our situation at the national level stands at 18%. Wasted, it stands at 5%, and overweight stands at 3%. And we are also able to see the trend that we have had from as early as 1993, where the cases of stunting cases have been high, but thank God it has reduced over a period of time to the current 18%, and the same applies to overweight. Wasting seems to be increasing just a bit. It is increasing by just a bit, but it is standing at 5%. We move to the next one, which then is also breaking down one of those indicators, and that is on stunting. Stunting by county, we have, of course, we have noted that at the national level it is 18%, and then deeper into the counties, we can see that the counties that are having high prevalence, like Kilifi has 37%, Kitui 25%, Meru 25%, Samburu 31%, West Pokot 34%. But there are counties that have equally done relatively better. In Kirinyaga it is only 11%, Murang'a 10%, Nairobi 11%. I think those are the lower cases. Then we can move to the next one. Sorry. The next one is on the trends in exclusive breastfeeding. We are guided that proper breastfeeding is meant to be exclusive for 6 months. That is, the child is just meant to get fed from the mother's milk. Now here we are talking of age 0 to 5. The sixth month, I'm made to understand, is meant for weaning, and so it is not fully exclusive. And so when it comes to that, the trend has been given, ranging all the way from 89 to 2022, and it is a graph that seems to be a bit funny, because it has been going down from 89 to 2003, and then from there it has now been rising. But in the current situation compared to 2014, it is somehow stagnant. I won't say that it's really gone down, because 61 and 60, if you apply the standard deviation, it will really bring you to the same thing. It will not really be any much different. And so our situation currently in terms of exclusive breastfeeding, for those mothers who are lactating, it is at 60%, which has really not changed from what it was in 2014. Then the next one is the childhood mortality rate. Here we are dealing with the situation with the element of mortality rates for children, and we are talking of neonatal mortality. This is a death of live birth. This is a live birth first, So we're talking, first of all, live births. For mortality, we are talking live births first. You are born alive, but this child has died within 28 days or the first month of birth. So that is the neonatal mortality. It is at 21. It is at 21 deaths per 1,000 live births. Then for the post-neonatal mortality, those who are dying between 1 month and less than 1 year is 11 deaths per 1,000 live births. And so if you look at the infant mortality, which is putting the neonatal and the postnatal mortality together, we are talking of those who are, the children who are dying before they celebrate their first birthday. They were a total of 32 in 1,000 cases. The next one is the child mortality, which is from 1 year to under 5. There were nine cases in 1,000 live births. And when we talk of now under 5 mortality, then we are adding the infant mortality and child mortality, which then gives us 41 cases per 1,000 live births. We then move to trends in childhood mortality, that is death per 1,000 live births for the 5-year period before the survey. 5-year period before the survey takes us back to 2017. Yeah, 2017. So under 5 mortality, we can see the trend from 89 coming all the way to 2022. It was rising from 89 up to 2003, and then started slowing down. So our situation got better, and currently we are at 41 per 1,000 live births. And for the infant mortality, we are 32 deaths per 1,000 live births. And of course, for the neonatal mortality, it is 21 per 1,000 live births. So at least for these indicators, in terms of child mortality, there has been quite some improvement as compared to the past. So the next one is on the trends. I hope you'll bear with me. I'm not far from finishing. But remember, we are still just dealing with the key indicator report. You know, the main one is massive. So Kenyans will be bombarded with a lot of statistics to get the indicators to help them. So then trends in this is the insecticide-treated nets, and we're talking of the ownership. And when we talk of ITN, the insecticide-treated nets, we are talking of the nets that have been treated at the factory, not the ones that are socked. You know, we get those whatever and sock them. No, we are not talking of that. I think that was applicable in the previous years, but I think in the last series of DHS, we are restricting ourselves to those cases that for the nets that are treated at the factory level. And why are we talking of the nets? It is because of the high prevalence of malaria-related deaths in the country, and so it is an area of concern. I know we normally undertake malaria indicator survey very regularly, but when we have a chance of this nature, we decided to take advantage of that and also see what is happening at the national level. And so we have these results that the households that had one or more nets, ITN net, is 54%, and those who had one ITN net for 2 people, for every 2 people in a household, they were 37%. And this our situation seems not to be doing very well for the first case, because we have moved from 59, ownership from 59 to 54. We need to really understand what is causing that. Then use of the ITNs, that is the next slide. Percent of people who slept under an ITN the night before the survey among all households. We are noting that for the under 5, they were 75 in the lake endemic counties. That is those counties that are commonly experiencing the incidence of malaria. And then at the national level, it was 51%. Now, for the pregnant mothers, because these are very vulnerable group of people, if they are attacked by malaria, we are noting that at the national level, it was 45%, and at the lake endemic counties, the cases were 75%, those who slept under net. So they are aware of this, and it is higher than the national one. Then percentage of people who slept under an ITN net the night before the survey among households with at least one ITN net is, we have 77 for children at the national level, and in the lake endemic counties, we have 80%. For the pregnant mothers, we had 75 at the national level and 82 at the lake endemic counties. So that is now broken down. So what is it that we are breaking down? We are breaking down the cases of those who slept under net the night before the survey among all households. And that is what is broken down now into counties. And we can see that the cases that had fewer, the counties that had fewer people sleeping under net, we have Nyandarua at 9%. We have Garissa at 13%, Samburu 10%, Marsabit 9%, Mandera 9%. But then there are those counties that had higher, that did better by sleeping under net. And these ones are basically those that are to the west. I can see there is Bomet at 76, Nyamira 81, Migori 76, Siaya 77, Vihiga 79, and so that is the distribution. We move to the next one. We are not far from finishing. Fever in children. This is percent of children under 5. Then for the children under 5, those who had fever in 2 weeks before the survey, there were 17 of them. This slide, I don't know why it is here, it should have been connected to the earlier one. Then they have the percentage of children under 5 with fever in the 2 weeks before the survey. So we had those who actually sought for treatment were 70%, and those who had their blood taken or from a finger or heel for testing were 33%. At least a good percentage of those who had fever 2 weeks before the survey were reported to have sought for medical attention in terms of treatment and also testing. The next one is on knowledge of HIV prevention methods among young people. Here, we have moved away from the perception that we had earlier on the HIV prevention methods in terms of perception, but we are focusing on the youth who are between 15 to 24. This question was applicable to those who are within the range of 15 to 24 years, and the remark is made there that knowledge about HIV prevention means knowing that consistent use of condoms during sexual intercourse and having just one uninfected faithful partner can reduce the chance of getting HIV. That is one of the knowledge that was being tested. Then knowing that a healthy-looking person can have HIV, and that we also rejecting the two common misconceptions about transmission of or prevention of HIV. That is, HIV can be transmitted by mosquito bites, and a person can become infected by sharing food with the person who has HIV. So those we were testing the knowledge of those misconceptions also, and we take note that at the national level, those who are within that age, those who have the correct knowledge on this, at the national level, it was 54 for women and 55 for female, which is basically the same. Broken down into urban and rural, higher knowledge was in the urban at 57 and 63, and like rural at 52 and 51. So HIV testing here, we normally undertake the Kenya AIDS Indicator Survey, which the last series in 2018 was KNBS, a modified version of the AIDS survey, and we had good results from that. But here we are not testing; we are just getting to find out from the respondents if they ever got tested and received results. And those who are tested in the last 12 months and received results. So those who are ever tested and received results, for women, they were 85%.